I don't know if you appreciated that song, but I'm wide awake. I am. So, hello everyone, and thank you for joining us for the final speaker session here in the Erie Crown Theater. And I'm Ann Johnson, and I am so happy to be joined upstage by an incredible panel. The genesis of this group was really putting together a conversation around what made virtual care different within a payer organization. And we really relied on some of our clients to help pull that perspective together, namely Ceres MD and American Well. So they were instrumental in pulling our fabulous panel together for us. And what we have this afternoon is what I think is going to be a fantastic discussion about the different elements of virtual care and how it plays out within a payer organization. So I'm joined, starting from my far left, the easiest to pronounce name, John Jesser from Anthem, but what is the correct title of your subsidiary?
Live Health Online.
Live Health Online, thank you. And then Genevieve Cruncho-Simpson, who's with Texas Health Resources and Aetna. And that's a really interesting joint venture that you'll hear more about. And then Pat Cornier, who's a physician with Kaiser Permanente on the West Coast. So as with the other panels, what I'd like to do is start with Pat and ask you to just give us some background on what you're doing, the organization. We, of course, know about Kaiser, but give us a little bit of perspective, and then we'll work our way left, and then we have some questions.
First, I think it's only fair to say you actually pronounced my name better than I do, so nice.
Thank you.
Nice job. I am a family physician, and so by way of background, that experience has a big impact on how I think about telehealth. But I work for Kaiser Permanente, which not only has an impact on how I, in my role, think about telehealth, but it has an impact on the way we can approach using telehealth and other advances in technology in the way we deliver care. I actually work as the Chief Medical Officer and Executive Vice President for Quality for the health plan and hospital part of the organization, and partner closely with the leadership and the providers in the Permanente Medical Group to configure all of the different assets that we have in the face-to-face space and in those venues of care that are not constrained by geography, the telehealth space. We actually began making investments in technology and information technology and the kinds of tools necessary to do this work more than a decade ago. We have the largest and most broadly implemented example of Health Connect, which is the Epic system in our system. And I just earlier today heard an interesting story about the way we have incorporated telehealth services into the work that we do. And it was actually in the context of a conversation with one of our physicians who was being asked by an outsider whether or not they do telehealth. And their initial response was, no, we don't do telehealth. And so they asked the question, well, when do you think you'll be introducing secure messaging? And he said, oh, well, we've been doing that for a long time. When do you think you might begin to do scheduled telephone visits or e-visits? Oh, well, we introduced that a few years ago. What about video visits? And the response was, I did one just yesterday, as a matter of fact. The point behind that story and the genuine feeling, as if there wasn't anything special about it, was that it was built into the method of care that's being given. Now, I will acknowledge that we have a challenge at Kaiser Permanente, and that is that while we can begin to incorporate those types of care without some of the constraints that a fee-for-service environment creates, because you have to create a billable event in order to justify implementation of the service, it doesn't mean that we do it consistently across the organization. And in fact, I think that that's one of our big opportunities, and it's one that we're embracing now wholeheartedly. We're working across the entire Kaiser Permanente organization to create consistency in the way we offer those services. The nurse advice lines, making them much more robust and much more consistent across the organization. Video visits and telephone visits and e-visits and secure messaging, and now even chat with Doc, available not just across a few select venues, but across multiple different specialties and consistently across the organization, helping not only to connect our care delivery providers to the patients that we're trying to serve, but with one another in new ways, and doing so sort of baked into the care. The idea, for instance, of a 23,000 member physician group, which is where we are right now, serving nearly 13 million members across 8 different regions. The idea of bringing together the world-class oncology expertise that we have to create virtual tumor boards that bring together those experts in a very specific and small volume cancer to be able to address the specific care delivery needs of a patient in Georgia when the seat of expertise rests in Northern California or Washington State. So a lot of those different kinds of opportunities that we see coming up. Now, as a payer, because of the nature of the way we pay for care, we have greater flexibility, and that means that we've been able to begin working with these tools years ago and begin to configure them in a way where we actually have the promise of creating real consistent offerings across our entire program. I do think, though, that the industry is beginning to make the turn, beginning to create environments where the payment models actually begin to support a wider and wider array of telehealth services, and do so in a way that will sort of free us up from the constraints that we see in the rest of the industry. That's going to put greater competitive pressure on us, which actually I think is great, because the greater the competitive pressure, the more momentum will be created for our organization. So see that as critically important. One of the things that we feel also is critically important is that experience design on both sides of the device is critical. That experience needs to be one that is rewarding and engaging, and an opportunity to create a joyful practice environment for those who are delivering care, but it also needs to be something that at every step along the way, with every moment in the course of getting care through any one of these different virtual venues, so any one of these telehealth venues, it builds trusts, it solidifies relationships, it makes people confident that the care that they're getting in that context is something that they can trust. All of those things are critically important from our perspective, and they also are a really important way for us to cement long-term relationships. One of the other advantages that we have in our environment is long-term relationships. And that means it creates for us the chance to invest in those technologies, invest in those relationships, and recognize that all along the course of that long relationship, any one of these venues, which is how we refer to the different telehealth and face-to-face venues that we have, any of those venues in that broad ecosystem presents an opportunity for us to make a difference in the health, productivity, cost, all of those things in our patients' lives. The last thing I want to make a point about, we've been struggling with trying to figure out exactly how much of an impact this has on the use of face-to-face visits or more expensive venues of care. We're just beginning to get some of the data now that suggests that there is actually a plateau or a reduction in face-to-face visits. And we see that as an important set of insights that will help us to determine what kind of infrastructure and capital investments we make as an organization in configuring our healthcare system of the future. Those are the kinds of things that I think we need to be able to have confidence going forward into the future in the work that we do as a combined integrated system. And I think that as the industry progresses and sees those promising opportunities and gets through some of the barriers that exist right now, it really will present at least the tools and the opportunity for some real transformation in the way we deliver care.
Got it. Thank you. Genevieve?
Yes. So again, Genevieve Caroon-Simpson. I am the Chief Operating Officer for this new joint venture between Aetna and Texas Health Resources. Texas Health Aetna is a brand new health plan, one of 5 that Aetna has invested in select key markets. And the basic premise of the joint venture, it's a big, bold bet that Aetna, a national health plan, has in terms of transforming healthcare. So the basic premise is that if it could more fully partner with a health system, the leading health system in a key marketplace, and really begin to align the incentives where the provider and the health plan are not economically competing with one another, but actually incentivized to be equally accountable to one another, but more importantly to our clients, but also our members, to manage their care in a holistic, efficient, but also coordinated way. We should be able to deliver something really unique and different. And so part of that journey under Texas Health Aetna, I bring a specific focus on innovation and focusing on member experience. My background is in healthcare strategy. I had been a healthcare strategist for a health plan. I've been a healthcare strategist for many health systems. But I started my roots in clinical social work. And so in many of my strategies, one of the things I always ask myself is, how will a member and their family be impacted by an initiative or a program? And so one of the things that we have invested in Texas Health Aetna is really looking at personalization in a local level. And so with that, in terms of an investment of our virtual care solutions, we have partnered with SiriusMD in developing a solution that allowed us to offer 24/7 access to our ER doctors as part of our clinically integrated network to any of our health plan members at no cost. And so what it creates in a marketplace such as Dallas-Fort Worth, where traditionally is a high cost marketplace that traditionally also has a high utilization of emergency rooms, we are able to essentially create a more convenient and seamless experience for the member, where we're not only essentially providing an alternative to an ER in that same platform. We have other care delivery partners in the platform that allows us to essentially redirect that care back to the primary care provider, in addition to being able to take care on the platform most of the healthcare issues that they may have that was presenting them originally. So part of this journey for Texas Health Aetna is continually asking ourselves, where do we invest? Where do we innovate? And our virtual care solution is just one of several that we're prioritizing to ensure that we're continually making healthcare convenient, simple, and accessible. But I think in terms of this journey, I'm very envious of Pat's model, because it's been one that's been built over time in a bigger ecosystem. And part of my challenge is, given we are a joint venture by two entities, we're still integrating, we're still developing, and over time, this joint model, we're very excited about the possibilities of what we can bring together, but it will take some time.
Cool. John?
Sure. I actually want to call out the people in the very back. They actually stepped over the red rope to sit in those back seats to not come closer. Anyway, I've been with humans will do whatever we do, right? So I've been with on the health plan side for a long time, and historically doctors would say, I talk to patients on the phone all the time. Why don't you health plans pay for that? And instead you make a mother bring her child in when I could have handled it on the phone, because I can't get paid unless I see her. And the health plan response, which is a rational response, was, we don't know what happens on the phone. If health plans started to just pay for phone calls, was it a 5-minute call? Was it a 20-minute call? Is there a medical record? Was there a prescription? A lot of the stuff that just happens on the phone it was so loose that most health plans wouldn't say, yes, we'll just pay for the phone call. So about 10 years ago, when I saw technology from American Well Company in Boston that many of you might be familiar with, I saw that technology. We could tell it was created by doctors. There was all those things that happen in an office visit other than the hands touching the patient. So there were CPT codes, there was ICD-9, ICD-10, clearly identifying the patient. There was a medical record, SureScripts prescribing, HIPAA compliant. as we looked at that, it occurred to me that really this is a visit. Everything that happens here is a visit. So as a health plan, Anthem should lead the way and should cover these visits. This should be a covered benefit. And so in 2012, we came out and said we're going to pay for these, to start out, these sort of urgent care telehealth visits. And the rest is, you know, been a long, great road. But at the time, there wasn't even mobile. It was web with a webcam. 2014, mobile came out, and that changed everything. So we started working with medical boards in different states across the country because, as many of you know, medical boards, when they think prescribing in the internet, it wasn't always a good thing. So getting in front of them, showing them the safety, the efficacy, and so on, to the point where in 2015 we were live in 48 states. Anyway, long story short, today in 50 states, 24 hours a day, 7 days a week, including holidays, you can be face-to-face with a board-certified credentialed doctor in about 10 minutes on a smartphone, tablet, from wherever you are. And that has become a very popular thing. It solves 2 or 3 things. It solves access. There are people who, it's 4 o'clock and they're not feeling well and their doctor's on the other side of town and there's no way they can get from here to there, especially in a place like Chicago. By the way, on the navigation, it said 20 minutes to go, 1.8 miles last night. So
Yeah.
anyway, there's
to Chicago.
access is not just rural. Access is urban. It's
Right.
all over.
Yeah.
Or it's Friday, and you know you can't get into your doctor till Monday or Tuesday. So when you cannot see your doctor, consumers were not really okay with going to the ER. Employers were not okay. FedEx is a client of ours. They spent something like $24 million a year on unnecessary ER visits, and they were just tired of it. So access to care, affordability, and also just convenience, something that health insurers were not usually guilty of, thinking about consumer experience. And so all those things made it make sense. That happened in 2016. We realized that behavioral health was a natural for this. So then we went live with 50 states, psychologists and licensed social workers. And again, as you all know, it's not easy to make sure that you have licenses in the states where people are. The technology handles all that, but you have to, it's not like you can hire 2 psychologists and go live. So with national employers, we wanted to offer 50 state coverage. In 2018, this year, we went live with psychiatrists in 50 states. These are scheduled appointments. And those, psychology and psychiatry weren't really about cost. It was really more about access. 1 out of 5, 1 out of 4, depending on the study you read, people aren't getting access to behavioral health with walking around with depression, anxiety untreated. When you talk about that, employers nod, they get that right away. Well, part of the reason they're not being treated is maybe they're not comfortable leaving work to go to the doctor often, and maybe they aren't comfortable sitting in a waiting room at a psychologist's office. Maybe they don't want to lie on the couch. So the ability to schedule these visits at home and be seen within 4 days for your first appointment and have a selection of providers to choose from, to have the privacy and the comfort of being at home, will make it more available, and people that need treatment will get treatment. So that's kind of where we led. Now there's breastfeeding support for new moms, which some employers are, you know, purchasing as part of a maternity program. We now have dietitians doing a healthy weight program with connected devices, connected scales, blood pressure coaches with blood pressure cuffs. These are wellness programs, but they're using telehealth to bring the professionals to the person in live video and make the experience better and more meaningful, more engaging. And so we'll see how all that works. A lot of that is pioneering and new, but as a health plan, we're supportive of it. Again, as has been said many times, the word telehealth will fade away. It's healthcare. Mm-hmm. You know, the envelope still needs to be protected. You can push the envelope, but we have to, just because we can do something with technology doesn't mean we should.
We should, yeah.
So having a doctor that's never met a patient, text them back and forth and conclude they need a prescription and prescribe is not really good clinical care. Live video is ideal. So we just have to have good sense, and I think convening in arenas like this and events like this through ATA will help the dialogue stay at a high level and help kind of keep some of the riffraff from trying to creep into the space.
Great, thank
Okay.
you. So you all have alluded to it a little bit. What steps do you take to ensure that information on interactions is fed back into some meaningful way so that the continuity of care is not lost? Pat, you want to start?
Yeah, it's a great question. I think an important one for a few different reasons. We do have the advantage within Kaiser Permanente that we are all on the same medical record. It means that anyone who is delivering telehealth services is able to look at the record at that point and make the documentation happen within that medical record or connect it immediately. And so that helps. And it helps in a couple of different ways, of course, establishing and assuring the continuity, which helps to ensure the trust of the patient who is using this venue. The other is it gives us a deeper understanding of the longitudinal view of care so that we can look more carefully at whether or not a given venue is well suited to a clinical circumstance and whether or not that episode unfolds in a way that winds up with the right kinds of quality outcomes that we want, the kinds of proper and effective use of the resources that we would like to see so that we remain affordable, and helps us to ensure that in the context of this really complex ecosystem, we're getting the kind of quality that we want to get out of it. The other dimension of that I think is critically important is because it is changing so rapidly, sort of in the same way that surgery has moved from the hospital into ambulatory surgery centers, you need to know that when you do that, you're doing so in a way that is safe. The same thing is true in telehealth venues. You need to know as you are beginning to move into more and more complex areas, you are doing so in a way that's safe, driving quality, and that can move and redirect that patient in a smooth and actually satisfying way into a different venue of care that may be better suited. And it's not just the medical record continuity that's important. In our environment, we have to own the whole experience. And that means patients coming to us, members coming to us who have a clinical and financial question, coverage question. We need to be able to help them to navigate effectively through those different sources of insight and solutions to their problems in ways that are continually more and more gratifying. The Cirrus chat with a doc is a good example because it's chat with a doc and it's chat with financial folks and member services, and being able to help patients, members navigate across those different kinds of venues to get their answers to the questions that they have, I think is really important.
Good. Genevieve?
Yeah, so for us in Texas Health Aetna, this is probably one of our key priorities, transitions of care and a seamless experience. And so it starts with making sure our providers, particularly our primary care providers, understand all of the key clinical models that we have, including our virtual care solution that we're really promoting to our members to ensure that their care is holistic and truly coordinated. Because the intent of the platform for us is not necessary to replace primary care. We believe that every Texas Health Aetna member deserves a good, engaged, high-quality primary care provider that is incentivized to manage my members' care, particularly if they have chronic conditions or a rising risk or a high-risk condition. But in terms of making sure that integration though happens, we ensured that coordination as well by staffing only clinically integrated doctors as part of our model. So one of the things about our model is that our ER doctors that are on the platform are part of our clinically integrated network, which means that they have access to that member's patient health record and is able to also coordinate that experience back to primary care. So that clinical interaction is not one that is transactional, that resides into an episodic experience, because ultimately what we're trying to just offer is a different additional access point to the member, particularly in an area like DFW where primary care access continues to be challenging. As much as 40% of my members historically have not had any relationship with a primary care provider, and so continually promoting additional access points and meeting our consumers' needs to where they're at and giving them alternatives such as the ones that we have with SiriusMD allows us to really give a level of consumer-centric options to our members. In addition to making sure our primary care provider is engaged, our doctors on staff are part of our clinically integrated network that ensures that coordination. Every Texas Health Aetna member, particularly those who are rising risk and a high risk patient, has a care navigator. So they are extensions of my primary care practices. They ensure that in case there are issues beyond traditional clinical care that the member may be experiencing, they are able to be a bit more accessible than my doctors to ensure that coordination of care also happens. And so it happens for us in a multifaceted way in addition to good data exchanges and technology investments.
Great. John?
Yes, several thoughts. So first of all, the platform itself, and it's not designed just for Anthem members, so anybody can download the app, the Live Health app. But what it does is, we know from CVS, MinuteClinic, and others that about half the population doesn't have a PCP or a relationship. And I'll take an actual controversial position that some portion of the population doesn't need one. A 35-year-old healthy male, may not necessarily need a relationship with a PCP the way that health plans have historically tried to force it on people. They still need coordinated care. There's no doctor better to treat somebody than their doctor if they have a doctor. But we find there are a lot of people that are medically homeless, if you will, generally healthy, but then they're stuck when they don't feel well and they aren't in a system and they don't have easy access. So anyway, when someone comes in and uses something like Live Health Online to see a doctor they don't know that they've chosen, they're asked to, if they have a PCP, if the system can forward the record to their PCP. So they can either put in a fax number, and believe it or not, yes, that's still the technology of choice for many PCPs. So they can put in a fax number or an email address and have that forwarded. The record, if you happen to have Anthem coverage, the record then also is imported several times a day into the Anthem platform so that primary care doctors that treat Anthem, have Anthem patients as their patients, can easily go and look through what's called the Patient 360 or the Provider 360 viewer. And so we have arrangements, for example, UC Berkeley in California, the student health system, there's a student health center, which is the PCP for the students, but 5 o'clock or 6 o'clock, whatever it is, they close. So they want Live Health Online to be the call coverage, but then the next day they want to be able to go in and see, who was seen and what took place. So they'll have a notice in the morning and it'll show them these are the 3 patients that had a visit last night and this one has amoxicillin or whatever. So anyway, that's how you assure it. But ultimately, telehealth isn't designed to be just an urgent care in a cloud. As you know, to enable that, ideally, as this becomes more and more a part of the ecosystem, then you'll be able to see your doctor or their designee after hours, and you'll be in their EMR, just like you see with Kaiser and with the Aetna Texas arrangement. So what we want to do is encourage more and more primary care doctors to adopt and integrate telehealth into the way they practice medicine. And that way the sort of call coverage doctors will be there for, your doctor. People always say, can I see my doctor? And the reality is your doctor's probably busy all day and would like to actually have dinner and go to sleep. So we can't assure you that you'll see your doctor at 11 o'clock at night on Saturday or 7 a.m. on Sunday. But if we make sure the system speaks to itself and the records make sure they get to where they need to be, we can be much more flexible.
Got it. Sort of moving a little further in terms of the end user and consumer engagement, we've heard a lot about consumer engagement. So either members don't necessarily trust their health plan, although Kaiser numbers are better than other carriers. Employers will offer a service, but there may not be a lot of uptake. What have you seen in terms of changes, if any, and has it improved or changed? Or Genevieve, would you start with that?
Yeah, so for us, one of the things we are beginning to really see is a more sophisticated consumer. I think naturally, as other industries continue to be catalyzed by increased consumerism, technology, and advancements, naturally people are beginning to ask and increasingly demanding that a similar experience be provided to them in the healthcare arena. Why is it that in a banking industry you can get 24/7 support when you need it, yet in many of our communities, unfortunately, we are limited in terms of office hours or geographic locations. And so one of the things that we are seeing is a consumer base that is looking for asynchronous communication, a different way to communicate and interact with their health plan. And it doesn't matter if their issue is related to the provider side of the house or the health plan system of the house. Ultimately, they want a simplified member experience, and so wants to have a simple interface to get their issues resolved in an efficient way. And in our development here in Texas Health Aetna, our virtual platform allows us to accomplish both. So, and so one of the challenge for us is as our consumers' demands gets higher, we are needing to also continue to evolve our business models, our member experience, and our clinical models to remain innovative but competitive, but also really focus on a curated experience that doesn't tend to overwhelm the consumer, but makes really these choices that they have ultimately simple and really hopefully better for their care and affordable.
Got it. John, can you take the question and perhaps offer some commentary in terms of regional variation or differences that you see in terms of engagement by employer type? Any?
Yep. Mm-hmm. So Amazon, Google, Spotify, you know, have, whether we choose to like it or not, have spoiled the consumer, and the race goes forward. So people have become very accustomed to wanting things when they want them and being able to do that, whether it's groceries or goods or anything. And healthcare is really historically, traditionally delivered so far different from that. That's why we see things like Net Promoter Scores for Live Health Online at 60 or above, up there with Sony and Samsung, things that a health plan historically would never have seen, or a typical medical group. And the quote I use is, the toothpaste is out of the tube. We're not able to go back. We have to go forward. And now there's broadband, there's rural issues. Not everyone has access to decent Wi-Fi, but that every day that's improving. Mm-hmm. You know, 5G is on the way. So we need to always support the expansion of broadband and access to this sort of thing. But we see it's not the millennials. You know, the sort of typical Live Health Online patient, user, is a 38-year-old mom. Tends to skew a little more female than male, mid-30s, early 40s. The millennials use technology. Again, they're going to push the envelope and want to text. They're not going to actually want to even see the doctor. But, you know, again, good medicine's good medicine. But we see that, but they don't get sick very often either, so they're not big users of healthcare. We see actually, we rolled this out to Medicare Advantage as a supplemental benefit, and the Medicare recipients are actually more responsive to campaigns. Of course, they answer their phone and telemarketing and tools like that, and they sign up, and they're using it, and they're valuing it. So I think it's going to be a little bit all over the board, but the challenge is we first saw employers like Pepsi and FedEx who have truck drivers, dock workers that didn't necessarily have data plans on their phones. They said, you know, they're not really going to do live video. They need to just sort of call an 800 number. Whereas the IBM employees and Verizons of the world and Google, they're carrying around devices all the time. We're seeing that melt away, though.
Okay.
You know, Medicaid as well. You know, the typical Medicaid, the population, they're young moms. They're on Facebook, they're on Instagram. So having live video visits with a doctor or having the child see a pediatrician is second nature. It's changed.
Pat?
A couple of comments. You know, there's the question of having the different technologies available in the hands of individuals, but the fundamental question I think that we need to be able to address is, do we understand the problems that our consumers, our patients, our members are bringing to us, and what's the best, highest quality way we can connect their problem to a solution that they find resonates with them? And that answer will vary a great deal from moment to moment with the same consumer and across different populations at different times. The young and healthy person can go in almost no time from someone who doesn't need very much to someone who needs a heck of a lot. And being able to navigate across that boundary, those different boundaries, smoothly and efficiently, I think is critically important. And so being able to construct a perspective wherever you happen to be, whether you're a health plan, a care delivery system, an individual provider, or an organization like ours that's integrated, you have to be really focused on what are the problems that those individuals are bringing to you, and what do you give to them as an array of options to solve those problems. And can you, in the context of that solution-building approach, move them smoothly and effectively from one venue to another? Because nobody's going to be perfect at picking the right venue at the beginning. In the same way that people aren't perfect at picking whether or not they should go to the ER tonight or to the office tomorrow. What they're looking for is actually the opportunity to make a wiser next choice, a wiser next decision in their own interests. And if we can use all of these different technologies to do so thoughtfully, regardless of whether you're a health plan or a medical group or whatever it is, you're going to win. One of the challenges that I think that the industry has in the telehealth space is, if that's the model, what are the different technologies that are available to do that, and how effectively can any customer like Kaiser Permanente or anyone else, how effectively can they bring those things together to build a great experience that bridges across those different venues? Now, we find that kind of challenging sometimes. And so if the industry can create an environment where that navigation is smooth and easy and effective from the perspective of the consumer, you know, we're going to have a lot of very, very exciting things happening.
Excellent. I'm happy to open it up before I continue to be greedy and take all the time myself. Yes.
I think that the ability to access care at all hours is an ideal that cost-wise and quality-wise is debatable. That just because you access, we know that just as far as the look at food, that our poorest communities may have access to food, but it's also the highest rate of obesity. And by giving access in these kind of across-the-board ways, we also have to rethink what on the physician side, who's going to be answering the phone, who's going to be performing that teleconsult, what the quality is. I mean, if you're a top doctor, I guarantee you're not the one who's going to be necessarily doing that. So this becomes the commoditization in some ways. It starts to call into question who is the appropriate person to be fielding those calls. And maybe it is appropriate sometimes if a patient still goes to emergency room. So with the big payers, have you seen, just because you get access, has that resulted? Do you have data that shows this?
Yes.
Yeah.
Yes.
That's a great question. Do you mind if I
Go
take a
ahead.
shot?
Would you repeat it and then?
Sure. So just because, it's a quote that one of the congressmen asked the CEO of Facebook, Mark Zuckerberg, he said, "Mr. Zuckerberg, just because you can do it does it mean you should?" Anyway, the question's a great question. Just because we can provide access 24 hours a day and because people want it, is that going to deliver the best quality of health care? What sort of doctor would be the one willing to take those calls and do that from a quality standpoint? Perhaps the quality might have been better in the emergency room. Am I capturing your question right? And has there been any studies from the big health plans to show sort of efficacy or I'm going to challenge you. This is because those are the normal thoughts, the right thoughts. But here's the story. The emergency room doctor is probably overtrained and great, and absolutely the quality experience will be great clinically. So going to be treated by a board-certified emergency room doctor, there's a great chance that the quality will be good. However, the consumer experience and the cost, for whatever reasons, and we spent years trying to figure out how to solve that, but they're not acceptable anymore. It's not okay. The companies that are paying the bills are saying, it's not okay, we can do better. Now, why don't we have care in the middle? First of all, by the way, most people don't seek care in the middle of the night. It's not like an elective thing just because now it's available. They sort of take care of all their work and their chores and their dinner, and then they say, I'm going to wait till 1 in the morning and go. We have very little traffic, even though this is across the country. But when someone does need care in the middle of the night, the fact that there are some board-certified quality physicians from good medical schools, but either because of raising a family or whatever, the daytime clinic hours maybe aren't their thing. They like the flexibility of maybe being with their kids during the day, doing a shift, a few hours overnight. We've been able to, because time and distance no longer matter, that you can find, let's say, a great doctor in Albany, New York, with a New York license who can see a patient in Manhattan now because it's telehealth, or the patient in Indiana or Connecticut because they have a license in those states. Suddenly, we're able to use technology to eliminate this barrier of driving, parking, getting up, and so on. To leverage the quality doctors, we have to hold ourselves accountable and make sure we're working with quality doctors. And that's absolutely, that standard should never change. Is it easy to get doctors that want to work the overnight shifts? No. There's a new specialty, nocturnists. And then there's Saturdayists, because we find it's really hard to get any doctors to want to work a Saturday. So it's a challenge, but we can't just not try to solve it. We have to try to solve it, and it's amazing. I got a call the other day from a company in Puerto Rico, which is a U.S. based, place. And these are board-certified doctors. They're Blue Cross of Puerto Rico doctors. They're bilingual. We've been trying to offer Spanish-speaking doctors to Spanish-speaking patients. And because of the hurricane and everything there, some of the business is not so active there, and because of the tax, for whatever reason, it's advantageous for them to do business in America. And they're saying, we can give you 20 trained psychiatrists, board-certified and quality, to help meet needs. There's a shortage in the U.S. So suddenly telehealth makes these things possible. But again, we have to have the highest standard of quality that we would always want to have. And we did do a study. I'm sorry, I'm going too long. We did do a study and published it and looked at the visit, and then 3 weeks after the episode of care, we created 3-week episodes comparing telehealth to ER, to urgent care, to the retail clinic, to the doctor's office, to answer 2 questions. People say, well, telehealth is not really solving anything. They're going to have to go to the doctor the next day anyway. It's just adding cost. And so looking at those 3-week episodes, the study concluded that, in fact, there is no additional follow-up. It's still not appropriate for everyone. Some people are referred on to a face-to-face or an in-person visit, but people who go to a primary care are sometimes referred on to a specialist, that the follow-up following a telehealth visit was not any different than the pattern of care for anything else. And we looked at prescribing and other things, and money cost was very significantly saved, even including imaging, prescriptions, labs, ER visits, admissions, anything that followed the visit for a 3-week period. So I thought that was very helpful, and we'll
That's
share it.
great. Pat, it sounds like you.
Yeah, first, I'm pretty sure my teenage son worked as a nocturnist for several years, because he was never awake during the day. You know, your question is a really important one. And yes, there are examples where studies have shown that properly structured, you get high quality and sometimes better quality in different environments that don't require face-to-face. However, as I said before, we need to be focused on the specific content and nature of the problems that our patients, our members are bringing to that interaction. It doesn't matter what time of day it is. What are they trying to do? What was it that prompted them to reach out to get further advice to improve the quality of their next decision? Now, if we can do that well and we can follow episodes to see whether or not that actual advice and that next decision led to the kind of outcomes the patient would want, that we would want for them, then we're doing well. I think we do have to be very thoughtful about the quality framework that we apply to these different venues of care in the same way that we've had to be thoughtful about how we make the evolution from inpatient to outpatient surgery venues. In fact, I would argue that the importance of that for telehealth is perhaps greater than any other. I had somebody say something along the lines of, nobody ever questioned whether or not a face-to-face office visit was a quality way to deliver care. Kind of making the implication that we shouldn't perhaps necessarily ask that question of telehealth. I think actually the opposite is true. As we became more and more aware of the variation in quality that exists in face-to-face care and began to spend more time understanding what quality really meant in clinical care, we did realize that the office venue has its own constraints and its own problems with variation and challenges with quality. And in that same way, telehealth will need to proactively understand that the risk of that quality being not as good as we would want is there, and we have to protect against that. We kind of alluded to some of the behemoths out there right now, like Facebook and others. Yes, people have become very accustomed to the convenience and the service and the turnaround time and the access that they get with an Amazon. But they're also very quick to punish those organizations when they fall short, when they betray trust, when the experience that they deliver doesn't meet their standards. And so we need to be aware that those same kinds of expectations, both in terms of the experience but also in terms of the clinical outcomes, are going to be the same ways that the community and the consumer will judge the telehealth industry. So let's be prepared. Let's create good, rigorous approaches to understanding whether or not these venues are delivering the kind of quality that we would hope. And where it does, great. Where it doesn't, correct. Where it presents more opportunities, explore those boundaries and do so in a way that's safe. I think that the question is well-founded in that it calls upon us all to make sure that the quality is good.
Got it. Genevieve?
So I think from my perspective, what I think about in terms of access, it's table stakes. It's providing a differentiated set of options, timely guidance to my members is something that we need to just do in an increasingly consumer-centric environment. I think about my members. There's a misperception that if you're a commercial health plan member, you may be a bit more affluent than most. Actually, what we have found is that increasingly our commercial population is not that dissimilar to a Medicaid managed care or a Medicare Advantage member. Because ultimately, increasingly, I think it's well studied that for many families today, if they had to find $400 out of the blue, they wouldn't know how to find that. They would actually need to use a credit card or some other type of loan to cover for that incremental $400 that they did not expect. And that's the reality that my members face. And one of the things that this platform allows me to do is give timely guidance from physician, an emergency medicine physician that's part of my clinically integrated network, to give my member timely counsel in terms of their options. So ultimately, if that member needed to really fundamentally go to an ER, since this is the same emergency medical group that is staffing both my ER facilities and my platform in a dedicated manner, they have no hesitation to essentially recommend an on-site ER visit if that's really what's needed. If they believe that this is something that a primary care provider could ultimately provide guidance and a treatment, we have same-day, next-day appointment, and our clinical teams on staff on the platform provides that service to make that appointment possible. So what we see is, I think it goes back to Pat's point, the platform itself it's not a simple model. It's really needing to understand what are the drivers to warrant the common areas of questions, inquiries, challenges that our member have, because ultimately what we've utilized the platform is multifaceted. We've utilized this for overnight additional access points, particularly if they don't want to go to an emergency room facility if possible. We've utilized this platform as an extension of our high-risk, high-touch care model. Our care model for our top 5% has a lot of on-site home visits that we have a multidisciplinary care team following our member. For a rising risk member, we have proactive outreach, and so we don't wait until our members reach out to us. We actually reach out to them to see if we can assist them. And so part of the real next challenge for these platforms is a business model challenge. Can we quickly enough understand the needs of our consumers and create discrete clinical models that are incentivized with our providers that makes fundamental sense, so that whether you are whatever you are in that patient's journey, we have a platform that has an ability to meet your needs and meet you to where you need us to be able to serve you. So it's something, though, that requires additional innovation, just because access is just the beginning, and we're looking to pilot more innovative models using the platform.
Great, thank you. A gentleman in the front.
Thank you.
You're welcome, Peter.
First of all, it's a really interesting discussion. It's great to see payers, all coming here and being so frank. My view is that the next era of sort of telemedicine, or whatever we're currently calling it, will involve many more asynchronous consultations that will include recorded video. In other words, you won't be just being sent, a still picture of some skin or a message. You'll be sent some sort of recorded video of a history, of a semi-structured interview, or of a child taken by their parents looking for early autism signs. What do you think about that whole series of asynchronous consultations from a payer perspective, and will you start paying for me to do it now? Because I've done quite a few of these.
So,
He's asking the payer to pay for something. What do you think?
Pat, do you want to restate it or?
Sure. The question is the fact that the technology exists and the ability exists to do a lot of asynchronous exchange of information, again, working to solve problems for patients. And why should we think that doing the exchange of information in a direct one-to-one synchronous way is any inherently better than doing so asynchronously? And if you can solve problems in an asynchronous manner, why not pay for it? I think, is that an accurate way of asking the question?
That's exactly my view. Absolutely.
Yeah. I think that's exactly the way we should look at it. It's not so much the methods or mechanisms used to solve the problem. It's whether or not you're creating an efficient and effective way to solve that problem and move on to the next step of care, further diagnosis, or whatever it happens to be. I'm chuckling a little bit in my own mind because one of the asynchronous ways that I used to come to understand the degree of sleep apnea snoring problems back in the day before we had all the testing was to have people do a tape recording of them sleeping at night. And I would listen to it and I would learn, and I would make help them make the diagnosis and solve the problem. It's really just a matter of, can you bring the information together with the expertise to solve the problem? That's adding value. So from my perspective, in the context of an integrated system, we do that in one way. In the context of other systems, finding a way to do that in other ways makes good sense to me.
Good.
So we're saying there's a chance.
Great. Genevieve?
Yeah, so for us, we believe that this is the future of where healthcare is going. Our bigger challenge in my marketplace is finding clinical providers that are willing to jointly build models with us that really looks to expand in terms of additional services that we can make available on the platform. One of the mechanisms to ensure that our providers on the platform and the health plan and ultimately for the benefit of the members are all aligned is creating value-based contracts. And so we have a value-based care arrangement with our clinical partners on the platform. And as we look to expand into other types of specialties and treatments and really make this asynchronous type of communication and interaction available, we're needing to do additional patient segmentation and claims analysis to really ask ourselves fundamentally, where can we add value? Because fundamentally, one of the things that we want to do is curate the experience in a way not to overpromise and then underdeliver. What we want to be doing in the development of our model is data-driven. Where does our claims and our patient segmentation work lead us, and how can we find the right provider partners who are willing to innovate with us to ensure the collective success of the program?
Great. John?
There's a few questions out there. They've covered it, I think.
Yeah, okay. Yes, sir. We did that on purpose. Yeah. Yeah.
I congratulate you on your successes. I've been following your stories for a while now. For states where the insurers are not as innovative and as open to reimbursing for telehealth or creating those innovative programs, what advice would you give to those healthcare organizations that are looking to partner to create that value for both you, the insurers, and us as the providers?
Okay.
So you're a provider, and so the health plan in your state may not be open to paying for telehealth. So what advice would we give? What state are you in? Florida?
That's shocking. Sorry. Do you want to take the question, John?
Just briefly, I mean, it's a Blue Cross of Florida question. They're a separate company, but I don't know I don't know the story in Florida with the position. So it's not mandated that health plans pay for telehealth, and you've contacted, like, for example, Florida or Aetna or Cigna, and they're not open to it.
So, without calling out names,
Yeah.
it's more difficult.
It's more difficult.
To start a program and create that partnership that was mentioned on the stage today.
Right.
When you want to create that value for the patient, you want to create the continuity of care for the patient.
Right.
But from a healthcare system point of view, it's more challenging to create that partnership with the insurer.
Right.
And so we're looking for that partnership, that advice. How
Here's the advice: find one health plan that will work with you, and create something unique for them that causes a stir in the market, and the other health plans will wake up.
Right. Increase market share. Market share talks.
We're all very competitive.
Yeah.
When someone thinks that they're doing something that's attracting the market, and the others they're gonna need to follow. We tried to do that in 2012 when we said we're going to cover these telehealth visits. We knew it would take other health plans a while to think through all that. And we just said, let's go. But you need to find somebody who's willing to go. And
I think
Best
too,
advice I have.
there's great value in thinking, okay, here's our market, here's our state, here's our environment. I see the value in this, I see the potential opportunity here, but a key partner is hesitant. What is it that they're afraid of? What is it in their history or experience or other things make them reluctant to introduce a new way of doing something? has that, you know, as an organization, have they found that trying something this way led to extensive and expensive exploitation because somebody found an angle on it that made them regret it later? And then when you get that understanding and have that conversation, okay, so what do we do in this particular context to unleash the opportunity without recreating that negative experience? I think those kinds of conversations can be helpful, particularly if you, in the space of an innovator, can recognize, I understand why this is kind of scaring you. Here's what we're doing to mitigate that, and here's how we constrain that in this first stage. I think that the other dimension of this is one of the reasons that payers are so concerned about it, not just commercial payers, but all payers are stepping carefully into this, is because of the accumulated experience of introduction of new technologies, new treatments, where it goes way beyond what the evidence shows it should, and it winds up being expensive, and there are negative experiences and bad outcomes. Anything that the industry in the telehealth space can do to mitigate and manage those things effectively is going to improve the progress. Because if we can talk about it in terms of the value added by bringing together those technologies and mitigate against some of those risks, you're going to move more quickly. And this is a space where we just got to move more quickly.
Jen?
So briefly, because I know we're running out of time, I'm familiar with the Florida marketplace. One of the things I would challenge you is sometimes if you don't have a willing partner in the health plan space, explore other venues, direct to employer, or in Florida, there's a healthy group of medical groups taking full financial risk or global risk arrangements. And so directly partnering with enlightened primary care providers, IPAs, MSOs, but also looking at potentially direct to employer arrangement, maybe alternatives, because I think this is where the healthcare marketplace is going, but I'm cognizant that this journey is not the same pace for every marketplace, but I'm convinced Florida will be around the corner.
And nothing gets the attention of health plans faster than direct-to-employer relationships.
Right, right. We are unfortunately out of time, so I want to thank our panel. You guys were terrific. I appreciated your candor and willingness to talk through so many of these issues. Please join me in thanking them for all this great insight today. And now we're the only thing standing between you and Chicago traffic to the airport, so
Yes.
thank you.